An effort to make you completely sick of seeing my face and hearing my voice, Chitra Krishnan thought it'd be good for me to do the next talk. So you have Chitra to blame for all of this. So we've been talking this morning about the name change, about the culture of the association, and wanted to launch the entire weekend of the symposium with points of view from our community, from our patients and our families. I'm going to shift gears a little bit. Still on the theme of Stronger Together, but talk about this from a scientific perspective instead of just the cultural aspect of things and the collective education side of things. So we're just going to take a few minutes from a science point of view and talk about why study these disorders collectively. What can we learn from the clinic, and what can we learn in research studies? So we've done a really good job of coming up with horrific names for all of these conditions. I'm not sure how many people here have had the experience of going to a healthcare provider, telling them you have, pick your acronym there, pick your abbreviation there, and having your provider Google it. Has anyone had that yet? Where they go into primary care and you say, I have neuromyelitis optica, and they say, just 1 second, and type it in. These names are important for a lot of different reasons scientifically. They help healthcare providers communicate quickly with each other and speak a common language sometimes. But in actuality, all of these conditions obviously are related to each other. And so if we start most basically from a scientific point of view and talk about a certain organ of the body, and what you're looking at is a slide of spinal cord, and on the inside, the butterfly-shaped dark area is referred to as the gray matter of the cord, and the outer pale area is the white matter of the cord. Every medical student in the country spends hours upon hours upon hours learning the anatomy of this part of your body, of this organ, the spinal cord. And there are lots of ways for spinal cords to get damaged. And so the goal of research is to try and understand all of these different ways and put it into a context so we can develop treatments. So one is to understand the cause of a condition. If somebody comes to me and they have a symptom, whether it's numbness or weakness or difficulty thinking or difficulty seeing or a combination thereof, it's great to put a name to it, but ultimately what I want to know is, why did person X get condition Y? Because if I put my public health hat on at some point, we would love to just prevent these. So if we know the causes, it would be great to retire the Siegel-Rare Neuroimmune Association in the future because these diseases go away. But the only way to do that is to understand cause. The other goal of research is to understand the risk factors for a condition. So there may be a singular cause, but some people may be at risk. So you could isolate populations, identify populations, and have them make changes in lifestyle, or have them take a vaccine and only take the individuals who are at risk. We want to develop diagnostics. People get misdiagnosed all the time, and what we're trying to do is come up with testing that is quick, easy, safe, efficient, cheap would be nice, in order to make an accurate diagnosis of what a patient has early on in the course of their condition. And obviously we would want to develop therapies. Now, therapies is a broad term, and for those of you sitting in this room, you are past the acute stage of your illness. You are past the first presentation. You are past those first 6 hours of having numbness, weakness, or vision changes. The people who need acute therapies don't know it yet. They are out there having the perfectly normal day you all had before this happened to you. There is nobody advocating for them but you. So the only people who have a vested interest, the only people who have a real need for acute therapies don't know it yet, but you know they need it. And so by doing research on a group of individuals who have a variety of conditions that can present acutely, we can get better for the generation of patients that are going to come behind you. And that's a critical part of the research we do. What we do in the first 6, 12, 24 hours can make a difference to what happens to the individual for 55 years. And so learning about that is incredibly important. But at the same time, we want therapies to lessen the impact of damage to the nervous system. And ultimately, we want therapies to restore function to those who have lost some level of function. So there's a lot of different therapies that need to be developed. and obviously, as I said, mechanisms to prevent these conditions. So here's an example, just to give you a sense scientifically of how we approach this. So a 40-year young individual presents with new onset numbness, weakness, progresses to paralysis, a story we heard with different ages throughout the morning. The MRI is obtained because this was not in 1964, and confirms that there's inflammation of the spinal cord, and they're told you have myelitis. They're treated with steroids and plasmapheresis, and they actually get 75% recovery of their symptoms in a pretty short order period of time. They're tested for one of the known antibodies that are associated with a condition like this, the anti-aquaporin 4 antibody, and it's negative, and the patient is sent to rehabilitation to continue progressing in terms of their recovery. And he or she wants to support research to focus on idiopathic transverse myelitis. They want to understand the biology, they want to improve the diagnosis, they want to improve acute treatments, they want to create restorative therapies, and they want to create prevention strategies. Ultimately, they want a cure for this condition. So here's the case of the 40-year-old who presents with new onset numbness, weakness, paralysis. MRI confirms myelitis. They're treated with steroids and plasmapheresis. They get 75% recovery, but their aquaporin 4 antibody is positive. It's the only difference between these two cases, a blood test between the two. And this individual wants to start a research organization focused on neuromyelitis optica. I'm not idiopathic transverse myelitis. I am neuromyelitis optica. I would like to understand the biology. I would like to improve diagnosis. I would like to improve acute treatments. I would like to improve restorative therapies, and I would like to create prevention strategies. Ultimately, I'd like a cure. The goals of each of these individuals are exactly the same. The organ that was affected was exactly the same. The impact on the spinal cord was mediated by the immune system. The only difference is in one individual, I can name the exact individual of the immune system, the exact bad actor, the anti-aquaporin 4 antibody, but in the other person I can't. For the first patient, they literally could have been diagnosed 24 hours before the aquaporin 4 antibody was even available, and they just didn't know they had NMO. These identities change on very small pieces of information. So how do we put this together? How do you prove the relationship? How do we take this information scientifically? Why is it important to include everybody scientifically when doing these studies? So in order to prove that an anti-aquaporin 4 antibody is actually related to the disease, related to the myelitis, we had to study individuals with transverse myelitis who did and didn't have the antibody. It was impossible to do neuromyelitis optica work without including individuals who didn't even have the diagnosis of neuromyelitis optica. There was a view in the world based on clinical descriptions that the only way you could have neuromyelitis optica is to have a transverse myelitis lesion of a certain length. And only in retrospect did we realize that's incorrect. You can have a transverse myelitis lesion that's small and go on to have the phenotype of neuromyelitis optica with recurring conditions. And we only understood that by including patients with a diagnosis of idiopathic transverse myelitis in the research. Furthermore, after the antibody came out and became validated and a useful tool, we realized there's a group of patients who really look like they fit the clinical picture of neuromyelitis optica. They had transverse myelitis and then optic neuritis, and I opened my textbook up just like the neuro-ophthalmologist did and put together a history of transverse myelitis and now vision changes, and they said, you know, this sounds like Devick's disease, it sounds like neuromyelitis optica, but the patients are testing negative for the aquaporin 4 antibody. So if we were to form an organization around the antibody, we would be losing a lot of patients who had neuromyelitis optica based on the phenotype. And what we found, and some of those individuals we would discover years later have the anti-MOG antibody. And so including patients under a big tent changes our understanding of the disease. And so there are multiple ways to classify disorders. There are multiple ways clinicians do it and scientists do it. We can do it based on the anatomy. This is my favorite. So we take people and we do an exam, we do an MRI, and we say, you have affected the white matter of your spinal cord. I now bestow upon you the title transverse myelitis. Then there are the individuals who show up and their gray matter is affected. And I stand next to the bedside and I do testing, and then I say, you have acute flaccid myelitis, and I bestow this title. And what's amazing is the number of clinicians who miss, me included. I'm not throwing anyone else under the bus. I'm including myself. The number of clinicians who miss people who have both. What do you do with those? Because I had one title for one and one title for another, and then everyone kind of sits in the corner and says, I don't know what to call that. Then we can look at brain white matter, and if your brain white matter gets affected, we say you have ADEM, acute disseminated encephalomyelitis. If the brain gray matter gets affected, maybe it's autoimmune encephalitis. If your optic nerve myelin is affected, it's optic neuritis. If the axons are affected, it's really bad optic neuritis. And so we can take the anatomy and come up with terms, but as Sandy pointed out in the very beginning of the morning, those terms have an impact. You are now siloed in a box, and for a lot of healthcare providers, the thinking stops because you walk in with your title. I have ADEM, I have transverse myelitis, and everybody's cognition stops on that and doesn't think about the other possibilities. So anatomy is helpful but dangerous. We can categorize patients based on time course, and the classic dichotomy is, did you have it once or more than once, as was evidenced by one of the questions? What's the problem with this scientifically? Everybody who's in the recurrent category, for some period of time, had only had it once. And so I don't know if you've only had one, whether or not you're going to switch categories to become recurrent. And in the setting of neuromyelitis optica that's caused by the anti-aquaporin 4 antibody, the idea was that you would have your event pretty soon after the first. Turns out that may not be true. There's documentation of people who have the antibody for 10 years before they have their first symptom. And in neuromyelitis optica phenotypes, we have individuals with the anti-MOG antibody who have gone a decade in between attacks. They had had one, but the recurrence doesn't happen for 10 years. When we opened our clinic in Dallas at the Children's Center, one of the questions around our practice was, for how long should we follow a child who had acute disseminated encephalomyelitis? Because every textbook says it's a monophasic event. It's a one-time event. And I give credit to my co-director, Dr. Harder, who said, for neuropsych reasons, we really need to follow these kids for more than just a year or two. That's great for neurology, but kids grow and cognitively things change, and something that wasn't a problem for a kindergartner might be a problem for a 4th or 5th grader. So we just set the rule. We are going to follow children all the way through elementary or high school, depending on when they entered, and lo and behold, only because of that did we start seeing kids years later come back with new neurologic events to find out that they had the anti-MOG antibody condition. And so diagnosing somebody as monophasic or recurrent depends on how much time you give them to have that recurrence. And then finally, there's the biology, which is where a lot of us from the immunology side come into the world. We like to categorize you based on your molecules. It makes us feel good. We like to know who has a B-cell mediated disease, who has a T-cell mediated disease, who had an infectious disease leading to their illness, who had an infection that didn't cause damage but then triggered those B and T cells to go in and cause the damage. Because we feel from a causation perspective, if we can get to your root biology, we'll have better acute therapies and ultimately preventions. And so the world changed dramatically with the recognition of the anti-aquaporin 4 antibody for neuromyelitis optica. This blood test changed everything we did in the clinic, because now we learned several things. One is we could identify people early on at high risk for recurrence. Number two is the textbooks lied to me. Doug's not here to defend himself, but he taught me wrong, because when he was teaching me, it was before the aquaporin 4 antibody, and he'd sit at the bedside and say, Ben, neuromyelitis optica is somebody with really bad transverse myelitis and really bad optic neuritis of both eyes. That's neuromyelitis optica. And I want my money back because he was wrong. With the aquaporin 4 antibody, we found people with mild transverse myelitis. We found people with brain-based disease. We didn't know it until we understood the biology. So ultimately, understanding the biology changes everything we do for a condition. But we need multiple types of individuals in the studies to learn the differences between the biology. There was work done with one biomarker in neurology, and I won't go into details, that said we have found a blood test to show that you have progressive multiple sclerosis. And they said, this is the blood test for it. Well, they only included people with multiple sclerosis in the study. And it did. It associated with progression. It also associated with just getting older. It associated with having a head injury. It associated with Parkinson's and Alzheimer's. It was not specific to multiple sclerosis at all, but they had a siloed study. So the assumption was this is a marker of one disease. You have to include individuals with a diversity of biologies if you're ever going to pick up on the pattern to define one or more patients. So scientifically, culture's nice, Sandy's great, it's wonderful that we all get together, but if I'm a cold-hearted research scientist, there is a reason to stick together. Our research is better. The biologic questions that I want to ask can only be answered if I have individuals with a diversity of conditions. I need individuals with monophasic ADEM, with anti-MOG associated disease, with aquaporin 4 neuromyelitis optica, with acute flaccid myelitis, with transverse myelitis. I need all of you involved in the research if I'm going to answer questions of any one individual disorder, which is why our clinic in Dallas with Cindy Wang and Kyle Blackburn, we are a neuroimmunology clinic. We're not just a TM or NMO clinic. The novel insights that come, those eureka moments that come relative to biology, come because of comparisons. There is not a single diagnostic test on the market, validated test on the market, that didn't get validated by comparisons of individuals who were hard diagnostic cases. So we take 10 people with transverse myelitis, and how do we know who has neuromyelitis optica? We had to have patients who went on to have recurrence and those who had idiopathic to validate that antibody test. The epidemiologic studies require a large enough base and controls. If I was doing acute flaccid myelitis work in Dallas and Dallas alone, and we see a fair number of cases in North Texas of acute flaccid myelitis, we would know absolutely nothing about this condition. It takes a national effort because these are rare diseases, and it takes an effort to include people who fit the pattern exactly, kind of fit the pattern, we're not sure, and people who clearly don't fit the pattern. So in order to understand what is happening in unique patient cohorts epidemiologically, we need a big tent. We need to include a larger number of people. And then ultimately the outcome studies. Why are there some people in this room who have had dramatic, remarkable, and near total recoveries? And why are there some individuals in this room who have had little to no recovery, or limited recoveries, or initially recovered and then started having problems later? The only way to get at the answer to the question of why or how is by comparisons. Because if I discover a biology in one person, there is no way for me to know if that is the explanation for their course without comparing it to others. And so we need that big tent in order to make these discoveries. Clinically, sticking together makes a big difference. So the taboo word that I could say in a rare neuroimmune disorder symposium is multiple sclerosis. Like, we're not MS. We're everything but MS, and we want to throw MS out. There are even things to learn from multiple sclerosis, and there's a lot to learn from each other clinically. Symptom management. Whether your spasticity occurred because of ADEM, TM, anti-MOG associated disease, or aquaporin 4, if the spinal cord is damaged and leading to spasticity, I am going to learn by seeing all of you and comparing stories. So as you're talking to somebody at lunch today about spasticity and you have transverse myelitis and they have neuromyelitis optica and something worked for their spasticity, there's a chance it will work for yours. And so being siloed apart from each other would limit our ability clinically to learn about symptom management. It would also limit our ability to learn from what works and doesn't work from a rehabilitation perspective. And we learned a lot about this with the outbreaks of acute flaccid myelitis, where we had been developing for 20 years, and our colleagues at the Kennedy Krieger Institute in Baltimore are at the forefront of this, of how do you do rehabilitation for a person with a spinal cord event, whether it be inflammatory or traumatic. We recognize with acute flaccid myelitis, where you get damage to multiple parts of the spinal cord, and you can get damage predominantly to that gray matter of the spinal cord, we realized the rehabilitation techniques we needed to personalize to the patient's type of injury. And then ultimately, we'll learn from each other relative to prevention strategies. Because if we can find out that there are unique causes to subgroups of you, we can start to chip away at this and start to prevent outbreaks and start to prevent the spreading of these conditions. So clinically, this makes a big difference to see all of you in my clinic versus just one select population. And then politically. And I will not get on a soapbox about politics today. I will talk about the politics of medicine. Rare is rare. We are not the tobacco industry with unlimited resources to go to Capitol Hill and push for different things. We are a rare disease organization. We are not multiple sclerosis. We do not have the resources to have an advocate at every session of Congress. And if we were to silo ourselves, it would be impossible to garner the attention of the individuals who can dedicate resources at a public health level or national institutes of health level to ensure that there is work being done on behalf of you and your families. And so we need to stick together, because the larger we are, the more resources we can get as an organization, as a community, to support the work that needs to be done. The resources can grow bigger when working together. So as I said at the beginning, everybody wants to have a group identity, and I understand it. Everybody wants recognition of uniqueness. I live in Texas. I understand this notion. They want their group identity and their uniqueness in Texas. But as I remind my neighbors in our great state of Texas, isolation is dangerous. Isolation is limiting. We assume that only those with a specifically defined group have insight about what is best for that group. And isolation leads to dogma. If I only have an acute flaccid myelitis clinic, I will make pronouncements about spinal cord inflammation that just aren't true. And so it is only through combination that we avoid all of these pitfalls. So we need to have a tent. We need to have a big tent, and that's the goal of the name change and the mission of the organization. Obviously, there is a limit to the size of every tent. So we are not going to start championing the cause of prostate cancer in the Siegel-Rare Neuroimmune Association. So there are limits to everything. Even though prostate cancer needs a champion and everybody with prostate cancer needs to be cared for, there is a limit to the size of this tent, and we can reasonably agree where that limitations are. And they're going to be dictated by a lot of factors, resources, and where the scientific and clinical overlap occurs. So at the University of Texas Southwestern and Children's in Dallas, when we named our clinic, the name we came up for our organization was the Conquer Clinic. And this was on the second or third beer in California. We were going through all the different acronyms, and we were on a pad of paper, or if I'm honest, it was a napkin, going through all the words we felt were important relative to our organization in Dallas. And the word that was at the top of our list on every single list was collaboration. And we recognized that we were going to need a village in order to approach these conditions. And so Conquer, which is the collaboration on neuroimmunology, and our mantra is to question, understand, educate, and restore, was built on a foundation around not focusing on one condition. So we were not the transverse myelitis clinic at UT Southwestern. We were the Conquer TM clinic at UT Southwestern, because we knew TM was going to learn from ADEM, NMO. We didn't even know about MOG and AFM at that point, and even multiple sclerosis. And so ourselves and, frankly, all of the colleagues I have that you're going to hear from throughout the day have embraced this notion of collaboration scientifically, and we applaud the organization for embracing the notion of collaboration at the advocacy level. And so when I started this journey, so Sandy talked about when he met me many moons ago, these were my girls, Hannah and Rebecca. Hannah at the bottom is the cheeky one who years ago was famous for asking me when I was going to give a transverse myelitis talk, "You haven't fixed that yet?" This is them now. And the older one now asks, "Do I have to wait for you to fix transverse myelitis to allow me to get my driver's license?" And I said, yes. And so she's going to come work in the lab because she's now really pushing for this to get done. But it's been a remarkable journey. There are things I didn't know as a parent when they were on the left-hand side of the screen that I know now, and there were many things as a clinician and a scientist I didn't know when this all started, but we are learning from you, and we are learning from the collective you. So we We are thrilled that this would be the first symposium after the name change, and I failed to say at the beginning, the name change officially goes into effect November 1, but for the rest of this weekend, I'll be referring to it as the Siegel Rare Neuroimmune Association. So thank you all for your attention, and we will keep going with the program.